I'm going to just talk about a story to Sepsis Screen, and it's really a journey in the details. I have no disclosures to make, and I would like to acknowledge the funding for some of this work was, as mentioned by Dr. Newmar, through AHRQ and NICHD, as well as the cooperative agreements through EMSC for the PCARN network. And I will say that, yes, I actually graduated University of Michigan undergrad and medical school, and Rob helped me not just today, but probably in medical school as well, as we were classmates, and that I have a very strong history of growing up in Michigan and really enjoying being here in Ann Arbor as a student. And I will say that when I was thinking back to this arc and my story, I will say that as an undergrad, I was the beneficiary of one of those research summer internships, I guess is what they were called, and there was at that time a really thick book that you went and looked at, and you flipped through and you found researchers that were kind enough and generous enough to take time, and undergraduate medical students who knew nothing and took them into their labs. And I actually had the benefit of being in Dr. Thomas Galerder's lab while I was an undergrad and learned how to pipette. And I think the other thing that I sort of learned was their lab meetings were totally transformative of how I thought about things and thought about questions. I didn't really understand 95% of what was being discussed, but I was still included, and I learned a lot at that time. And then as a medical student, I did the same thing. I thought, well, that was so productive. I got to, as an undergrad, learn a lot and hang around Ann Arbor in the summer and not take any classes, and that was a lot of fun. And as a medical student, between our first and second year, there was also an opportunity with, again, a very thick book, I'm sure it's all electronic now, of people who were willing to take on medical students as researchers. And I was, as an undergrad, a English major. So I was having a little transition issues of coming into medicine and not reading any novels anymore. And Dr. Joel Howell agreed to allow me to look at perceptions of pain in literature as my summer research endeavor in my first and second years of medical school. And I learned a lot from that. Again, had a great experience and did my first poster with printouts and spray painting the glue on the back in the old days, and really learned about that and presented for the first time for that too. So really my arc of research does start very early in my education at the University of Michigan, and I try and remember this every time I am approached by an undergrad or a medical student to try and be generous and kind, and if I can't fit them in, to find a person who will fit them in and help them in that journey. And then, as mentioned, I went on for my training in pediatrics and pediatric emergency medicine in Philadelphia, at the Children's Hospital of Philadelphia, and I started to notice the same things, but in different ways. And that's really what I want to talk about today, is an understanding of looking at things in certain ways, and that's what brings us to research. So these are all pictures, not taken in Philadelphia, but taken from the best parking lot in Chicago. At my children's school, the parking lot has a view of Lake Michigan. It's from the other end of your guys' view for Lake Michigan. But this is Lake Michigan, taken every morning that I drop my kids off at school, which isn't every morning of the year, but good number, and taken at the same time in the same place, looking at the same thing. And this one year, I actually took somewhere close to 150 pictures of the lake. And as you can see, this is just a small number of those pictures. And it looks pretty different a lot of the time, and sometimes it looks pretty similar. But there are things to view in each of these, and I'm going to talk about that. So, you know, what I realized when I was doing pediatric emergency medicine is that the care that we give our children, the emergent care that we give our children, can be variable. And as pointed out in the IOM report, Emergency Care for Children, Growing Pains, there is this, within this variability, there is obviously at times outstanding care, and at times care that significantly can be improved. And this variability presents an opportunity for improvement for all of us. And when I started looking at that, I realized that the administrative data that I had been working with was really not adequate to truly explore the quality of care given to children, and that there were limitations in the exploration that we could do with the vast data that we had, but that was lacking in some ways. And at that time, there were advances in health information technology that piqued my interest. And those were particularly the movement to the electronic health record and the ability to do natural language processing with data from within that electronic health record. And so we, together, a group that involved the PCARN network, and I'll speak about that in a minute, proposed this grant to AHRQ, where our aims were to develop an emergency care visit registry that was built directly from the electronic health record data of the patients seen in the emergency department. And then from this registry, which we built, we would collect and determine benchmarks of care of stakeholder prioritized performance measures, because to this point there weren't any benchmarks even for us to tell how we were doing compared to others. And then we would take this and report performance to individual providers and to sites. And so we thought this hasn't been done before in this way, and we wanted to study it, so we did a staggered time series study. And I'm going to talk about each of these components. There's many of you in the room who know a lot about PCARN, and a lot of familiar sites that I've had the real benefit of learning from and interacting with over the last years with PCARN since PCARN's inception in 2001. The University of Michigan has been a strong site within PCARN and is currently the nodal site for one of the nodes, and has really been a particularly important component of the success of PCARN. So I won't speak to you too much about it, but just to mention that it is the first and currently only funded pediatric emergency medicine network in the nation. It's funded by the Emergency Medical Services for Children through HRSA and Maternal Child Health Bureau. It currently funds 6 nodes and 18 sites nationally, and we have been in existence since 2001. And hopefully we will continue as we move forward. And you can find a lot about this network at www.pcarn.org. So go and explore. Prashant Mahajan is the nodal PI. Alex Rogers is your site PI and HEDA PI, and they're both hugely informed and been involved in this for a long time. So reach out to them, because there's a lot of exciting work and areas of collaboration within the network. One of the studies that the network undertook was led by Evie Alessandrini, and I was able to participate in that, where we decided that we wanted to look at this variability of care in pediatric emergency medicine, and there were not performance measures that really pertained to us. There were lots of performance measures about emergency medicine, most of them about adult patients, or there were performance measures in pediatrics, but not about emergency care. And so we came together over a 2-year period and came up with a 60-measure balanced, stakeholder prioritized quality performance measures that we thought related to the most important things for us to first look at in pediatric emergency care and the quality of care that's provided. And those measures are actually available online through the EMSC improvement website. You can just get to it when you're at PCARN. If you want to go to tools, right there on the left side there, you can go to tools and it'll bring you directly to here. And if anybody is interested, you can look at those performance measures and pick out ones that pertain to what you're interested in studying. So we took that and then our idea about the PCARN registry. And as I said, the whole goal was to take this, to build into existence this registry that would allow us to measure our quality performance measures, which we had just defined, to come up with benchmarks of them, to report them, be the mechanism of reporting how we're doing with these quality performance measures, and then to measure improvement. So the way that the PCARN registry works is that the patient is seen in the emergency department and an electronic health record is generated. And then we take information from this electronic health record on all patients, all pediatric patients, seen in the sites included in the registry. And we have a monthly transmission, which I'll talk about in just a few minutes, related to what we take and how we do that, that goes through validation and de-identification, and then goes to the University of Utah, which is our data coordinating center for the PCARN network. We compile that data from the University of Utah into the PCARN registry, and there in the middle. And then from information in that registry, we take some data directly through discrete variables, and then other data through natural language processing, and we apply that and come up with our performance measures. We then do benchmarks on these performance measures, and then we provide report cards to providers, and our overall hope is that we are improving care to children. So I take this time to shamelessly promote the registry because my goal is to really do collaborative work as we can across the nation. And so in order to understand what you can do with this, you need to understand the scope of the registry. So these are the variables that we have within the PCARN registry. Now, as I'm speaking in an emergency medicine day, you guys know we're obsessed with time. Everything about when they come, what we do, how we do it, how quickly, and where we disposition them. So everything that you'll see here is associated with a timestamp. Excuse me. And so we have the site, we have the patient identifiers, a unique identifier that longitudinally links patients, so we're able to look across time patient visits, and then an encounter unique visit, so we tell what belongs to that encounter. We know the demographics of the patient, the date of birth, sex, race, ethnicity, zip code, and payer. And then we start in our visit information. So we have our triage category, our chief complaint, the arrival mode. We have date of time if there was notification that the patient was coming, either by EMS or the pediatrician or an outside hospital for transportation. We have the time the patient graced the emergency department door, the time of sort if the site does a sort pre-triage, the time of triage, and then the time of discharge. We actually have information because we're looking at quality of care of all providers that touch that patient. So we actually have a unique provider IDs for the providers and then the date and time that they signed on to the patient's care and then their role. We have every vital sign that was obtained in the emergency department associated with a date and time, including temperature, heart rate, respiratory rate, blood pressure, oxygen saturation, and weight. We have the medications that the patient told us that they came in on, the medications that we gave in the emergency department, and then the medications that we discharged the patient on with prescription. We have asthma scores, pain scores, and Glasgow coma scores, all associated with date and times. We actually have the free text narrative that was generated for patient care, the author type, and the date and time associated with that narrative. We have for radiology, all of the radiology orders, start date and time, so the time the study started, the time the study was available to be seen, and then the report, date and time availability, and the actual free text of the report. We have laboratory values that were obtained in the emergency department, any lab obtained, and then its results. We have ICD procedure codes and CPT codes, diagnosis codes, and then your ED disposition. And that's where, because we were looking at a quality of care in pediatric emergency medicine, we ended this registry. So we have a lot of deep information during the ED visit. We have very little information after for admission to this point. And so if you were admitted from the emergency department, We have your hospital discharge date and time, so we know hospital length of stay, and then also your vital status on discharge. And that is something that you'll see as I talk that we're working on, but there in total are our variables for the PCARN registry. So the sites that are included, the 4 original sites that started in 2012 were the Children's Hospital Colorado, Children's Hospital of Philadelphia, Children's National Medical Center, and Cincinnati Children's Hospital. And these 4 hospitals, 3 of them have a main emergency department and a satellite community emergency department. So that allows us to see differing kinds of care and patient cohorts related to where the patient is seen. We brought in 3 additional sites in the last year with data starting in 2016, and there were Lurie Children's Hospital of Chicago, Milwaukee Children's Hospital, and Nationwide Children's Hospital in Columbus. And then, as you can see here, we're currently bringing in the University of Michigan, which we're very happy about joining, and University of California, Davis. And we are in the process of onboarding. Elizabeth is here today, and she has done a lot of work, Elizabeth Duffy, in getting your site onboarded, and has been super helpful in that, and has an amazing team, including Rich Medlin, who I can't look out there, but maybe here as well this morning. And we will start having data from the University of Michigan and University of California, Davis, starting in 2018 currently, but we're going to backfill to 2017. So there's a large number of hospitals and a variation of hospitals and interesting differences in where the hospitals are and the patients that they are seeing. And then just to give you an understanding of the scope of the registry, this is through 2016. We haven't actually updated these numbers yet through 2017. Excuse me on that, but you can imagine it's just getting a little bigger. So we have currently more than 2.5 million visits when we take into account 2017. We have over 900,000 unique patients, a lot of diagnosis, a lot of lab results, medication orders, radiology tests, and over 13 million narrative documents. So there's a lot of information there that is waiting for all of you to think about collaborative work that we can accomplish with this database. And then we have over 1,000 unique providers who have received report cards over the course of this study, and I'll speak about that in just a moment. So again, our goal was to uphold the tenets of QI that we had rigorously defined and effectively and efficiently measured outcomes, that we had transparency of data. We talk a lot to the sites about what the data is and how we're getting it, that we validate the data rigorously, and that it's an iterative process that allows for ongoing assessment and reassessment. So what happens is February of 2018 is just completed. We'll allow a month after the completion of the date. So the end of February 28th occurs. We then allow 30 days after February 28th to allow for data maturity, to allow for all the diagnosis codes to be put in and the test results to come back, et cetera. And then on March 29th, the data from February is submitted to the Data Coordinating Center. We have a 2-week process that is data validation and grouping some of the data and going through it and producing the report cards, so that the report card for February of 2018 is actually emailed out directly to the providers and the sites on April 17th. So next week, our sites will be getting their report cards from February. The report cards are visits that are attributable to that particular provider. So we all know that one of the things about quality improvement is that it's easy to say, well, yes, that's how we are doing, but that's not how I am doing. And so what we are doing is giving you information directly on the provider, directly on the patients that that provider saw or that site. The report cards are not identifiable to anybody but the provider. You can utilize them as you wish. And that is a component of, one, being part of a network that is gathering data from differing sites, as well as that when we started this and were part of a study of ARC, the providers were the study subjects. So we had protection in place for them that the report cards are identifiable only to them. We've had providers use them in many different ways. I had a provider contact me and ask if they could use it for their promotion dossier. And I said, of course, you can use it for whatever you would like. And so we've had uses in many different ways. There's stringent case identification for the cohorts, and I'm going to go through some examples of that. We tell you how many cases are involved, so you can look at numbers, and so that the issue of small numbers can be identified. There's a graphic representation of performance over time, there's trends over time, and then we allow for comparison and benchmarking across your site, across the network, and using what is the achievable benchmark of care. And the achievable benchmark of care is a measured level of excellence that has been used previously. It's mathematically determined, it's reproducible, and it allows providers with high performance to define what can be achieved both within a site and then generally within the network. And it allows us to take into account small numbers so that providers with small numbers of relevant visits do not have an overly high influence on the benchmark. So this is a picture of our report card of some different components of our provider report card. So as you can see, there are provider performance information, so you know what your median time is and your interquartile range or your proportion, both graphically and also numerically. You have the site performance is identified, the overall network performance is identified, the achievable benchmarks of care both at site and network levels are identified. We show you the variability of providers within your site so that you, as the provider who gets the report card, are identified by either a black rectangle, a green rectangle if you're better than 75th percentile of other providers in your site, or a red rectangle if you're worse than 25th percentile of other providers at your site. And then you can see there the span, each of those gray rectangles actually is a provider, at least one provider. Some providers are overlapped, but that will allow you to sort of see where you are in the span. And then we have trends of time over time of both the individual provider and then trends of the site and the network. This is a picture of our site report card, and so you can see as our sites increases, we have more sites, there's more rectangular bars, and that allows the site leaders to benchmark the site across other sites. So as an illustrative example, I just want to talk about antibiotic use in viral illness. So our goal here was to, as a performance measure, was to decrease the use of antibiotics in viral illnesses. So really, though we didn't necessarily say it this way in the manuscript, unnecessary antibiotics. These patients are patients who have viruses and don't have any bacterial infections and really should not be getting antibiotics. So what we did is we looked and we had all children less than 18 years of age that were in the registry. They had to be seen and discharged from the emergency department. So they couldn't have left without being seen, but they needed to be discharged because we felt like if you were admitted to the hospital, then you really had maybe some other reason to get an antibiotic that we might not be capturing. So these are patients that are going home. They have no chronic care conditions identified at all. They have no bacterial infections identified. And then as just sort of a fun thing we wanted to do, we decided that if you had a diagnosis of pharyngitis, we actually went in and looked, did you see if you had a rapid strep done? And that rapid strep had to be negative for you to be included. So if there was a positive rapid strep, you were excluded as well, because in the ICD-9, this has changed in ICD-10, but in ICD-9, pharyngitis, a rapid group A strep pharyngitis was not captured adequately, and that it just came across as pharyngitis often. So we wanted to be able to allow those patients that the provider provided quality care and got a rapid strep, that patient would be excluded. So if they didn't have any group A strep pharyngitis and they were diagnosed with a viral acute respiratory tract infection. So if they made all of those criteria, diagnosed with the virus, they were included in the cohort. So again, our goal was if you had a cold, we wanted to make sure that you didn't get antibiotics, either oral, IM, or IV. So we looked for antibiotic administration either in the ED or on discharge. We looked at patient characteristics, including age, race, ethnicity, triage acuity level, gender, and insurance status. We look at ED characteristics, both main emergency departments and satellite emergency departments. And then we looked at provider characteristics. So were you peds emergency medicine trained, EM trained, pediatrician, PEM fellow, or advanced practice nurse, or PA? So in 2013, the emergency department visits made by children that were included in the registry were 413,000. Of those, 344,000 were discharged home. Of those that were discharged home, 304,000 met exclusion criteria. And then that left us, even though there was a big chunk that were excluded, that left us with almost 40,000 children to evaluate for this study. And interestingly, the overall antibiotic use of children in the study that had viruses and no concurrent bacterial infections was 2.6%. We looked at the main emergency department, 2.6%, and satellite emergency departments, 2.6%. So there was no difference based on your location of care. Interestingly, peds emergency medicine trained and general pediatrician trained who see kids in the emergency department both had 2.8%, and the advanced practice nurses did better than the physicians in providing appropriate care for these patients, with only 2.1% having giving antibiotic use for kids with viral illnesses. So again, our overall rate was 2.6%. What we found is that if you, as a patient, were non-Hispanic white, you actually had 4.3% of those patients were given unnecessary antibiotics. Non-Hispanic black, 1.9%, and Hispanic, 2.6%, with other at 2.9%. So what we found is that these differences were statistically significantly different, and that the differences in care were related to race and ethnicity. We then went on to do multivariate analysis and adjusted for age, insurance status, acuity level, ED type, ED site, and provider type. And again, with our referent range up there at non-Hispanic white, we found that black non-Hispanic patients, Hispanic patients, and others had were less likely to receive antibiotics for viral acute respiratory tract infection than white patients. So overall, we found that although the antibiotic provision in the emergency department for viral acute respiratory tract infection is low, when we're looking at this, even in just these 4 sites, we studied 40,000 children in just 1 year. So even though at one site your rate is low, if we look across the country, the ability to impact the number of patients, if we can decrease this even further, can be vast if we're talking about the number of children that come to the emergency departments nationally for acute respiratory tract infections. And that we also saw differences in the provision of antibiotics by patient race and ethnicity, and that non-Hispanic whites were more likely to receive unnecessary antibiotics than minority patients, and these differences persisted even after adjustment. And again, this is something we are going to look into more of, why there is this difference in care. It has been seen in other instances. So again, there's a difference in care in children with minor head trauma, with white patients receiving unnecessary CAT scans more frequently than other patients. And so I think that within PCARN, we have a disparities working group that is trying to figure out ways to study this, and we're working with Tiffany Johnson and Monica Goyle nationally to look at implicit bias of providers and how that may affect the care that is provided in the emergency department. So again, it's just one way of sort of looking at the same thing from differing times, differing views, differing ways. And this large registry allowed us to start looking at the quality that we had already defined in other studies to determine how we were doing. And so I'm going to switch gears just for a little and say, yeah, I was looking at lots of different kids and lots of different performance measures. And then I became really interested in looking at one view a little more closely. And so we started thinking about how we could take this registry and how could we use it to improve care in one aspect, and how could we use the rich clinical data that we had to evaluate the diagnostics and therapeutics and outcomes of one. And I know that this group is very involved in improvement in treatment of sepsis and in looking at sepsis throughout the research continuum, from basic science work onward through identification and therapeutics. So I know I'm teaching to the choir or preaching to the choir in this respect. But this is also something that I've been interested on, the emergent presentations of infectious diseases of children throughout my career. And as we started to see the ability and depth that we had in the research using the PCARN registry, I really wanted to focus in on that one view of that one day and look at sepsis. And I do believe, as was recently written, that we need to move this into the public and political space in order for things to change in sepsis. So I'm always happy to talk about it and to think about how we think about it. I'm going to not spend a lot of time about this. You all, I think, know that sepsis is the intersection between SIRS and infection, and that it dates back, to the time of Hippocrates, and comes from the word, the process of which flesh rots and wounds fester, and that it is this progression, as we see, for sepsis, severe sepsis, and septic shock. And I know that this continuum and these names are in flux currently, with a lot of work being done in general in treatment of adults with sepsis more than children, and we're lagging behind in our understanding of these words and these concepts. But what brings this all together is an understanding of organ dysfunction and the leading of SIRS and infection leading to organ dysfunction. Recently published, I'm sure you all know, was the consensus definitions for sepsis and septic shock for adults. And that it's the life-threatening organ dysfunction caused by dysregulation, and septic shock is the subcategory. In pediatrics, we have not had such clear-cut definitions brought forward. I do think that they will be coming soon, and I've been talking to people who are working on that, that we don't have the pediatric organ dysfunction score exactly the same as SOFA, that there is PSOFA criteria, but it's reliant on some non-specific and delayed criteria, and that it's difficult. So I want to sort of have this in the back of your head. In pediatric sepsis, just defining sepsis is actually a component of difficulty currently, and figuring out how to call that outcome is something that intrigued me. So with a group led by Fran Balamuth and I, we looked at pediatric severe sepsis in children's hospitals using the Children's Hospital Association FIS database. And we found that about 4% of total admissions to pediatric hospitals are related to severe sepsis. And even though it's only 4% of admissions, we found that these admissions are very significant. They lead to long hospital stays. Most children are not hospitalized more than 2 to 3 days at most. These were hospital length of stays of 16 days. They were ICU length of stays of 5 days. They were hospital costs per patient of $65,000 per patient and there was a mortality rate approaching 17%, which in pediatrics is certainly devastating to us and is different than many pediatric illnesses that we see. Even though in pediatrics you can't just look at mortality as an outcome in sepsis, because it does happen infrequently, this did show you that of those hospitalized with severe sepsis in pediatric hospitals, the mortality is actually quite high. We then went on to look about, well, what can we do about this? And we looked at antibiotic therapies, and what we found, this is a single center study at Children's Hospital of Philadelphia, we found that if we delayed antibiotics for more than 3 hours, there was a significant increase in the odds of mortality in pediatric patients with sepsis. And so you can see there the difference between 1 hour and greater than 3 hours. So we knew that getting antibiotics in, as others have shown as well, was very important. We started to look at about how to do this and protocolize treatment, and can that improve our outcomes in pediatric sepsis. So we found that with protocolized treatment, we were actually, this is protocolized emergency department treatment. ED treatment initiated while in the ED, decreased your PICU length of stay for these kids, decreased our hospital length of stay, decreased our unanticipated transfers from the regular inpatient wards to the PICU, and then increased organ dysfunction free at day 2. So patients without organ dysfunction at day 2, the proportion of those patients was significantly increased by protocolized treatment started in the emergency department. I know that you guys here, and I talked with Marie Gleason yesterday about this, are a significant part of IPSO, and that the IPSO collaborative run through Children's Hospital CHA is doing amazing work at helping pediatric emergency departments and pediatric centers nationally come on to use protocolized treatment and identification through both the emergency department and inpatient settings to improve pediatric care of sepsis, and that this as a quality improvement consortium is doing amazing work. I will say that my interests began to evolve into challenges in sepsis recognition, because for me that's the difficulty in the emergency department, the needle in the haystack. And so you may have a 3-year-old patient in triage who's febrile and tachycardic and has an okay blood pressure and is okay on room air, and you might have a 16-year-old who is also febrile and tachycardic with the exact same heart rate and tachypnic because they're 16 with the same blood pressure and room air. And you know, the good thing is that oftentimes these 3-year-olds, by the time I get to see them and their antipyretics have kicked in, they're running around the emergency department room eating a popsicle. And the other chance though is that somewhere in this group is going to be the patient that is going to progress and go on to sepsis and organ dysfunction, and that my goal is to find that patient. There's definitely, though, a fine balance in what we want to do, and that even though there are high stakes for missed cases, there's a resource-intensive treatment on the flip side that is not without its own possibilities of potentially harming our patients if given to the wrong patients, or harming other patients as we move resources from one patient to another in our fixed resource situation. So we looked, again, with Fran Balamuth, we looked at improving recognition of pediatric sepsis patients in the emergency department using a vital sign-based electronic alert, and then coupling that with clinician identification. And we did find that the electronic alert had decent sensitivity and specificity, but that was significantly improved, obviously, with utilization of clinician judgment. And we found that as we implemented this in a QI perspective manner, we were able to decrease our cases of missed sepsis in the ICU. But there was still room for improvement. And so going back to that one view and that one picture, what started bugging me was, I'm not sure if you can see it, but if I go back to all my pictures, there's this blue dot that was there. And as I looked at my lake pictures more and more, that blue dot bugged me more and more. And I just want to sort of say that to me became this, I needed more information. So I think what happened was I honestly probably needed a new phone that I was taking pictures on, and there was a digital defect there. And so, what this came to symbolize for me was this defect of understanding what we know about pediatric sepsis and what we don't know. And that I needed to take that and fill in that defect. And so again, it's taking this view of the overall lake viewed from afar. It's interesting, and you can see differences in it, looking at the same place in the same way, and you look overall and you look at quality and you can see differences. And then you hone in on one picture, and then you hone in on one defect. And so basically that's what we did when we decided to start the grant that we call Ped Screen within the PCAR network. And the overall goal of that grant is to improve the detection and treatment of pediatric sepsis in the emergency department setting. And so what we are currently doing is we're taking our basis from the PCAR registry of the electronic health record registry, and we're expanding that to include inpatient care. So of all the information that we have from the emergency department, we're now taking that and looking at the inpatient care that is provided to those patients. And the reason we want to do that is because our outcome has to be organ dysfunction. And at times organ dysfunction is very easy to determine when you're looking at, say, a bilirubin level. And that's what you're going to look at, or you're looking at other liver function tests, and all you need to do is follow it across time. But if you're actually going to look at CNS organ dysfunction and you want to look at altered mental status, that's a whole different ball game. And you're not going to have a discrete variable most times accessible in the electronic health record. So we want to take the depth of the data we have and use natural language processing as well as discrete determination to actually come up with allowing the computer to determine organ dysfunction. This is not manual chart abstraction or reading these charts. This is an automated determination of organ dysfunction because that's our outcome. And then we want to derive and validate a predictive model of pediatric sepsis that will identify organ dysfunction within 48 hours using data from the first 4 hours of care. So that's my goal, because that's the time I get to see the patients, and I need to not send that patient home who's going to progress to sepsis and have organ failure and send them home without recognizing that they're going to get sicker. So we're going to use information within the first 4 hours of care to determine and predict an outcome. And it's really exciting. We're currently in our first year of this grant. We are spending a lot of time coming up with the inpatient variables and how we will pull those out of the disparate electronic health records, because we have sites that are Epic, we have sites that are Cerner, and anybody who's worked with the electronic health record knows that if you've seen one electronic health record, you've seen one electronic health record, and that each one, even within sites, has variability, even within the same vendor. So we're spending a lot of time prepping that, but our goal will be to start with that information and come up with our organ determination, and then use machine learning to come up with the predictive model. And the goal will be to see the view completely and bring it back to the patient and use this information to then bring back to the quality collaboratives like IPSO, who are doing great work but are working with limited information about what we really should be implementing. And so we'll take that information and utilize it in the patient care. And that's my arc to date. Hopefully it will continue, hopefully with collaboration with others, and hopefully with filling in those holes that just are evident as you sort of hone in more and more and more in one way. And, you know, just bringing it back to the ability that I had coming out of this institution to really have the ability to look from pipetting to pain to electronic health record and reading the story as it moves forward and moving that story on for sepsis. So, thank you.
I was just going to open up the floor for questions for Dr. Alpern.
Hi, thank you for a great talk, Libby. So in the last thing that you were talking about, so if you are trying to identify those patients at risk, you have through the PCAR network and through your previous work, you've increased the percentage of patients who are getting antibiotics early, I presume, or that's happening as a national trend. It sounds like you need patients who are going to be demonstrating organ dysfunction and not doing so well in the first 48 hours. So how are you working with that if your care is improving over time through the quality work in identifying those patients who will have presumably abnormal markers or predictive elements in the EHR that will lead you to find that group who are sicker?
Right. I think that's a really insightful question. I think I appreciate it. Yes, as we do better, that number of patients that will have organ dysfunction becomes smaller and smaller and smaller. And our identification of them. What's interesting is that the most difficulty is the ones that we identify and treat and don't go on to organ dysfunction at all, right? Those are the ones that we save from that, as opposed to those that we treat. And as we know, despite some of our best treatments, patients still get sicker. I think from that group, those that get sicker will have some identification of knowing that there was a time period of what we got, and then taking that information and using it to look at organ dysfunction. Even though we've gotten better and better and better, we still think that there's enough patients that are there to allow us to have information that's identifiable and through machine learning techniques to come up with a predictive model. So yes, if at the end of our grant, everybody has been identified prior to our ability to look at it, we won't have a result. But that'd be okay if we've gotten that far. I think, and we know, even through IPSO and other ways, that we're not perfect in that, and that there is definitely an area of scope that we could find that predictive model of those patients and help them.
Thank you.
Yeah. Yeah.
Hi, Libby. We talked last night about sepsis in general in children, and we're an IPSO site, and we're now going to be on this registry, and we're in FIS, et cetera. So we have a great opportunity. But I wanted to call out that Bob just pointed out to me last night that there's new work being done to try to change how we take care of sepsis in adults, or modify it, because obviously the old surviving sepsis, SEP1, et cetera, is not clear. And I think you're right. I think we're going to be chasing identification. What is sepsis? What does it really mean? For a while. And we don't really know what the perfect set point is for kids in fluid and antibiotics. I think we are pretty clear that we should give antibiotics, but I think there's so much more information about how much fluid, how much of this, when do we do this. And as we're studying it, things are coming online, such as biosignatures. We have different biomarkers now that might help to inform us for earlier and earlier organ dysfunction signs and symptoms rather than sort of the crude stuff we have. So I'm hoping in the end that between FIS, between PCARN registry, between IPSO, that a lot of that stuff will actually come together to give us better stuff. So I really appreciate the work and appreciate you coming today. Thanks.
Thanks, Marie. I completely agree with you that that the opportunities there are vast to truly understand how we can improve care, not just identification. And as we're building this component out of the registry and expanding it, we definitely are keeping that in mind, so that our goal, as we have used for just the electronic health record registry of just the emergency department, to use it as a source of comparative effectiveness research, and that we can look at differing treatments by site or by patient, by provider, and look at how we, and then look at the outcomes of that. And so our goal is that this will be a vast repository of data that is open to people to do that kind of work, to see is there variation just in the sites that we can utilize to identify best practices or the best treatment plan in fluid, or the use of lactate, or the use of other therapeutics, normal saline versus lactated ringers, et cetera, that we can utilize to see our best outcomes in sepsis. And then I think that in addition to that, this is ripe for linkage as a biorepository to an electronic health record data repository. And that is something that we're currently doing at one of the sites. We have started linking blood samples to our electronically derived variables at one site, and if we can make that network-wide, that would be huge as well. The goal to look at biosignatures and or RNA or other proteomics, if we collect it, then we don't need retrospective chart review to link to the outcomes related to those biosignatures or other blood tests, DNA or RNA or proteomics. And so that would be a great goal.
A quick question. The differences that you noticed in the kids, the non-white and the white children being treated for viral symptoms, did you notice that in the bacterial group as well, or was that across the board?
That's a really great question. We did not look at the bacterial group because they were excluded for our treatment, for our performance measure. So, you know, we haven't thought of that. So maybe that would be a group to look at and see if there's differences in those patients that actually should receive antibiotics. Are there differences in cares by race and ethnicity as well? We didn't look at that. Well, thank you very much.
Libby, one other
Yeah.
question.
Yeah.
Again, thank you for a wonderful presentation. We've got other speakers today that are going to address kind of the intersection of technology, artificial intelligence, and medicine. And I was wondering if you could comment briefly on the challenges that you faced in integrating a defined data set across multiple EHR platforms, and where you possibly see that going in the future.
Yeah, so that brings up a really good point that I usually have a slide that lists all of the people who have worked on this, and a thank you slide. And honestly, it's actually gotten too big to list if we've brought in new sites. And I think that the key to this and that answer is actually finding people who are passionate about this from varying perspectives. So we have people on our group who are informaticians, clinicians, data analysts, and IT specialists, and we really need to collaborate together to do that, because my specialty is not in knowing where the data is in the back of the electronic health record. My interests are finding the data that I think we need, and then helping and having other people help find that. So to your question, we have harmonized data from 4 health systems now, well, actually now 7 health systems and 2 EHR vendors. And the real issue and recognition of that is that you need to have someone at that site who is willing to work, you need a team at that site that is willing to work where there's specialization in clinical understanding of the data, and then specialization of data repository and of where the data stands, and then specialization of how to get it out. So I think that there's 3 kinds of people, and if you can bring a team together of those 3 kinds of people, that'll be really the way that you can be successful in that. We are just venturing into the artificial intelligence component of this. We've done natural language processing in the past, but we've not done any machine learning or artificial intelligence related to it. And I will say, just for those of you out there that get summary statements for grants, that the summary statement we initially got on our grant application for this said, get yourself a real computer scientist. And I took it to heart, and it was the easiest thing I ever did to improve a grant. And I found a great computer scientist, and it was a good recognition of, you don't want someone who plays it on TV. You want the real deal. And so I think that's the key, is just good team membership and collaboration. So.
Again, thank you very much for a wonderful presentation and for coming here today to be part of our Arson Research Forum. Thank you.
Thank you.